The light green one.
I want to change it to white.
We all need it, but we all need to change it to one specific color together. Okay, so when we reference it, you're not like the white one, and then you're like the pink one,
I
and
like
then I'm
the.
like the
I
purple one.
want it to be like plain white because I like to write. Like I don't want when it's a different when it's blue I can't.
Under design. Under design. Okay, what do we do? She did white.
Yeah, so I could write in and highlight. Is this for exam 3 or 4?
4.
All right, wonderful to see you. Good job on your test. The median score, the median was 89%. The range was 64 to 100. The average was 86 plus or minus 4. Okay, on the stats, so I can tell you that much. So good work, really good work. As we move forward, next week on Monday, is your labor and delivery test. It will probably be a comparable length, right? I'm counting the nutrition, and I'll continue to count the nutrition questions for both. I think that's been very helpful for our class. In that interest, I want to point out that there is a short guide to intrapartum nutrition, and I promise you I can come up with 5 questions for that. And I did want to make sure that you saw it. I don't think you did. Is that too dark? That's good. That's good. Point this out. Basic principles of intrapartum nutrition, by the way, the uterus is contracting, right? Usually once every anywhere from 2 to 5 minutes, right? About a minute long, sometimes a minute and a half, right? So think of that uterus, which is a large muscle, as doing reps for hours. If you were running a marathon, this is equivalent to running a marathon, right? Do you need calories if you're running a marathon? Do you need fluids if you're running a marathon? Yes, you do. Okay. Can exhaustion potentially and lack of adequate calories, can that lead to ineffective, less effective contractions? Yeah. Intrapartum nutrition is a thing. In general, the digestion and passage of solid foods and peristalsis slows in labor. Blood flow is being more directed to the uterus, right? However, liquids keep rolling through and keep absorbing at approximately the same rate. Okay. It is helpful to know that for a patient who is having an uncomplicated vaginal delivery for whom there are no anticipated complications, no existing or concerning complications, for whom a cesarean is not anticipated, and who is doing well, whose baby is doing well, and who is not planning regional anesthesia, they can have a regular diet. They may not feel like steak and eggs, but they can have a regular diet. For the patient who wants regional anesthesia, there is a small but real risk that the anesthesia can go high. There is also a risk of hypotension that can impact placental perfusion and impact the fetus. The general thought is that once the patient is that clear liquids are a good choice for a patient who has regional anesthetic. Some providers want ice chips, but the evidence is that clear liquids are fine. And there are, diet has been a hotly debated subject. It's hard to do randomized control trials. But I want you to know that ice chips or clear liquids are fine with an epidural. Okay. If the patient is having a cesarean, there is a small but real risk that they could need general anesthesia. that maybe the procedure lasts longer. Maybe the patient has a hemorrhage and it takes longer. Maybe there are other things going on that could have happened that could lead from a regional anesthesia cesarean to a general anesthesia. And with general anesthesia comes the risk of aspiration pneumonia. So if a patient is having a cesarean section or needs a cesarean section, we preferably want them to be NPO for 6 to 8 hours. Do we always get 6 to 8 hours? No, we do the best we can. So if things are not looking so good for your patient in labor, the heart tones are, you're doing intrauterine resuscitation measures. Are we going to want to give the patient a regular diet? No. We might then move them to NPO or ask the provider, should I make this patient NPO at this point? We might need to adjust our IV fluids accordingly, right? But be aware that, that if we anticipate a cesarean or if conditions are changing to lead towards cesarean, we need to move the patient to NPO status. Okay. That's the basics of nutrition. Sound good? And this is all written up for you. I'm just like giving you the short version really quickly to make sure you. So it's right here. And so, but by the way, vomiting is not unusual in labor. I'm not really worried about a patient compromising themselves in terms of fluid or electrolyte balance until they vomited more than 3 times. Okay. So, all right. So here's a little bit more information for you. And I just want to make sure you knew that was there. Now then, so I think you have everything you need for your third test. You remember that you have an L&D summary, and you also have a medication summary. Is medication administration a big thing on labor and delivery units? Yes. Will there be meds on your test? Could be. Could there be management of analgesics? Analgesic considerations, yes. And there is a summary guide for you. Remember also there's some optional quizzes you can look at and test yourself. Again, the optional quiz was an old prep quiz we used to use, and it is a little more basic. It's more at the recall and understanding level. And so be aware it's a little more basic than the actual test. So now we're going to talk about postpartum care. Your objectives and planner here. Your study guide is here. The fourth test is on postpartum newborn, and here is your PowerPoint. I also want to point out that you have pre-briefing instructions and a reflection to do, and you will later this month have a debriefing on this activity. There is a virtual simulation on postpartum care. I recommend looking through the videos if you haven't already, as well as the Hemorrhage Care algorithms. Stanford has a wonderful breastfeeding video series, by the way, and I highly recommend it. So I want to make sure you know all those good things. And let's get into today's goals. So you have all learned how to conduct a focused postpartum assessment. How many of you have checked the fundus so far? A few people? Yeah, awesome, awesome. And you have looked at assessment for patients who have had a vaginal delivery or a cesarean delivery. So our next steps are to learn more about care planning and the prevention of complications. I am going to go kind of quickly because we only have 2 hours due to curriculum changes, and there is a lot to cover. And let's see, this is not a happy remote control. Okay. So planning for, first off, we should be thinking ahead about postpartum, right? We should be planning for recovery, right? Some of that planning was when our patient was prenatal, and we asked them about if they had help at home. We often recommend people put some meals in the freezer. We also are looking at their very serious medical risk factors, right? So when we had Akila, we looked at her risk of preeclampsia, right? We looked at the risk of infection maybe for Melody, who had prom, right? And we minimize vaginal exams to try to reduce the chances that she would have an infection, right? Can infections in labor and delivery lead to, and procedures in labor and delivery lead to infections later on? Yes, they can, right? So one thing builds on top of another. One thing leads to another on labor and delivery and postpartum units, right? So our biggest risks are hemorrhage, infection. Does preeclampsia go away immediately with delivery? No. Is that still a problem? It sure is. Yeah. Those are some of our biggest ones. And of course, we're always going to follow the nursing process. We're going to do a risk assessment because prevention starts prenatally and it continues through labor, delivery, and beyond, right? We're going to keep going, right? In our hospitals, anybody notice the column in EPIC that says mute, M-E-W-T, mute? And this refers to maternal or gestational early warning triggers. That's what that abbreviation stands for. EPIC is in the background looking at the patient's CBC, their hematocrit, and all of these other factors, and using scoring systems to flag us when something adds up to a serious risk, right? They're used to identify clients who are at risk. They trigger clinical pathways. They alert us, they alert the provider, so that we can put in process interventions to help prevent the patient from developing morbidity or mortality. And again, our most significant ones are hypertension, preeclampsia, hemorrhage, infection, also other cardiopulmonary complications like stroke. VTE. Okay. So our most imminent risk, as I think you've already noticed, is bleeding, right? So what assessments did we make prior to delivery? CBC. When was the patient's last CBC? What was it? Did they need a new one on admission? Right? How about their platelets? Is that be a part of that? What's their hematocrit, their hemoglobin? What are their platelets? Right? In the first 2 hours post-birth, many of you have done fundal checks, right? Did you check vital signs pretty frequently too? Yeah, absolutely. Absolutely. So we also do risk factor assessment for postpartum hemorrhage, and you learned a little bit about that early, back in the first week of the quarter. First off, life is not a risk-free adventure, right? I think part of what makes life fun is the risks we sometimes take, I think. But we don't want too much fun, right? No such thing as zero risk. If a patient is considered low risk and has no significant risk factors for hemorrhage, we will send a clot only to the lab. In other words, a tube of blood is drawn and held onto. Okay? If the patient is moderate risk, the patient needs a type-in screen. If you are a triage nurse admitting someone for labor and delivery, or maybe a scheduled cesarean section, are you reviewing the chart and looking at these? Yes. Are you getting these orders? Yes. At 2 in the morning, will the provider know about this patient? No, it's on us. Yeah.
So this is just for postpartum hemorrhage. Is this also calculated within the mutes?
Yes. Yep, it is.
So these risk, this, when you're talking low risk, moderate risk, that's based on mute.
Well, the risk assessment that I'm reviewing with you here is embedded in the mute.
Okay.
Yep. Mm-hmm. Yep. So conditions that require a type-in screen include prior uterine surgery. Oh, by the way, if EPIC has downtime, do you need to know this? Yes. Can we, mutes are helpful as a fail-safe, but ultimately it rests on our shoulders. Because what if the computer system is failing us? Like it did this morning. Who knew computer systems sometimes have gaps in them, right? So just a reminder, the computer, we need a relationship with our computer. We check, we have each other's backs, right? All right, and our patient, right? All right, prior uterine surgery, like a patient has a VBAC, TOLAC. Multiple gestation, twins, triplets, right? More than 4 prior births. What the old-fashioned term for this is grand multipara. Prior postpartum hemorrhage, large fibroids, has to be the large one. Little 1 centimeter fibroids, there's another. I'm talking big fibroids, like the size of a softball. It has to be a sizable fibroid. If I'm seeing at least a 6 centimeter fibroid, then I would have some concern, depending on the location, okay? Macrosomia is suspected. If we suspect a baby who weighs more than 4 kilograms, again, we're talking about over-distended uterus. The larger the uterus is, The larger it grows, the more it has to contract to cut off the blood supply to that placental bed. Are those terms coming back to you from the first week? Yeah, and so that's what the concern is there. Obesity is also an independent risk factor for hemorrhage, and a moderate risk factor, and chorioamnionitis. Infected tissue does not contract as well. And you know, remember me asking if anybody's seen cellulitis before? Red inflamed tissue does not contract well. And remember that contractility is our main way of stopping bleeding. Coagulation is secondary. It's important, but much of the blood control is from contractility. High-risk patients, they must be type and cross-match for 2 units of whole blood. Sometimes this is adjusted based on your individual patient. For example, I remember delivering a patient at a crit of 18.5 pre-delivery. And no, that was not an error. The hemoglobin was only 6. Patient was profoundly iron deficient. Membranes ruptured PPROM at 35 weeks. She went into labor at 36 weeks. Am I worried about this patient? Are they high risk? Yes. Do I have much blood that we can afford to lose? So did we need more than 2 units of blood potentially? Yes, we type and cross for 4 units in that case. So sometimes you might need to adjust this. Remember, we also individualize plans of care. The standard of care is a minimum. That's also a good thing to know. The standard of care is a minimum. If your patient needs potentially more blood, then they need more blood, right? Okay. Abnormal placental implantation, low line, placenta previa, suspected accreta. Remember, the accreta is when the placenta embeds past the endometrium into the muscle or beyond, right? Coagulopathy, platelets of under 90, crit of 30, and at least one other risk factor. Active bleeding on admission, more than bloody show. So the patient appears to be abrupting. That would be a patient like Mina, right? And so that would be a patient like Mina. So part of her labs would have also been to be type and cross-matched. 2 or more medium risk factors. Okay. We may also consider preeclampsia, prolonged first or second stage labor, vacuum forceps or cesarean delivery, retained placenta, which is when a placenta hasn't been delivered for 30 minutes. Normal placental deliveries within 30 minutes. Oxytocin greater than 24 hours. If it took more than 24 hours of oxytocin to deliver the baby, how responsive is that uterus to oxytocin? Not very much. Is it going to contract well? No. Yeah. So this is a warning flag for you. Mag sulfate administration. Okay. Polyhydramnios, because again, the uterus is extra large with polyhydramnios. So there's much more contraction necessary. Okay. So we began our assessment, and you can see that some of these things we're going to know before the patient's admitted, right? Like if they're having twins or triplets or have fibroids, some things may develop during labor, right? So nursing management and prevention includes vital signs, fundal assessment and massage, bladder management and catheterization, PRN. You know, certainly if the patient can avoid on their own, that's preferable. But if a patient cannot void, and their uterus is growing bigger and it's deviated, that's not good, right? That bladder needs to be relieved. Remember that uterine deviation is a sign of an overdistended bladder. Usually deviates to the right, and a full bladder can prevent the uterus from contracting effectively and controlling bleeding. And even if the bleeding is okay now, if the uterus is deviated, we need her to empty her bladder. That patient needs to empty their bladder in order to prevent bleeding. Okay, we don't want to wait till she starts bleeding heavily. That patient starts bleeding heavily, right? Does that make sense? Yep. So we've got, and do people feel like peeing after they've just had a baby through their vagina? No, or when they're new post-op and they just had their Foley removed not too long ago? No, not so much. They lose a little sensitivity initially. Sometimes we need to put people in the position of voiding and turn on the water or Some nurses will use a hat pin and put a couple drops of peppermint. Peppermint oil is a little bit of an irritant to the urethra and sometimes helps people feel like they need to void. That's an old postpartum nurse trick. So, anybody see that? There historically has been a bottle of peppermint oil at the postpartums. Okay. We need to quantify blood loss. Blood loss is quantified at each and every delivery. If the patient is within normal limits, meaning moderate or less bleeding, we will just continue to estimate with our pads. This is scant, this is light, which is also correlates to small. Some hospitals call this small rather than light. This is moderate. Moderate is roughly half a pad. Get the tails. So moderately half a pad. A heavy amount of bleeding is saturating a pad within an hour. This is too much. If patient is saturating a pad or more within an hour, that is too much. We need to start weighing. And everybody remembers that we are weighing pads. We quantify blood loss by weighing them. A gram of blood is a mil, equal to a mil. 1 gram is equal to 1 mil, right? Another nursing duty is medication administration. We routinely give 10 units of Pitocin IV or IM. It can be given in the anterior thigh of the patient. I've also seen it during cesarean, I've actually even seen it injected directly into the uterine muscle. That's an IM injection. Yeah. That's not something they do at private. Probably give it IV. If you go into the OR for a C-section, you'll see the IV bag hanging, and you'll often see that the CRNA has a syringe already stuck in the bag, labeled, ready to inject the Pitocin. And they're, to go into the bag of ringers. So, because it is considered routine as a prophylactic treatment. And yes, Lauren.
So, C-section, you also said that a surgeon will massage the uterus to
Correct.
have it contract.
Yes.
But having witnessed one, I'm starting to think, is that a smart move if the uterus has then been entered surgically? So you're massaging a muscle that has a big cut in it. Does that cause
Absolutely, they need to massage it. Yeah. It's the placental bed. Remember that the placenta is usually in the fundus, and they're massaging the fundus in order for those muscles, those muscle fibers of the uterus to contract and cut up, leading to the placental bed. Most of the blood is coming from where the placenta was. And yeah, that absolutely is. Yeah. And I know it seems difficult. Remember, our patient can't feel it, but people can hemorrhage during a cesarean too. Yeah.
This IV Pitocin, is it for every patient or just patients at risk?
It is actually recommended for every patient. Does a patient have a right to refuse it? Yes. Yeah. It is for every patient. The term for this is called active management. And that is that after the baby is delivered, every patient gets 10 units of Pitocin. This is also recommended by the World Health Organization. It is recommended for international health care as well. It saves people about 200 to 300 mils of blood on average. And so, and iron is hard to absorb from the gut. There are lots of people who are iron deficient. Lots of adults, gestational adults who are iron deficient and who could use that. Okay. So remember our trauma assessment of blood loss. You lost 15% by the time you have orthostatic tachycardia, up to 25 by the time you have resting tachycardia and orthostatic hypotension. And you've lost between 25 to 40 by the time you have resting hypotension. If we wait till we have this, we have waited too long, right? So we need to act on the quantification of blood loss and not wait till we see changes in vital signs. That doesn't mean vital signs aren't important, and if we're starting to see signs, we need to act fast, right? And we need extra hands. We need more people. Okay? So happily posted in your Canvas module are the CMQCC standards. And there's both a flow chart right here, and I'm going to go to the other one. It's a little cleaner in terms of viewing. They are both the same, the summary chart. And this is more of a table. see, stage 0, every patient giving birth. Assess for risk factors and ongoing quantification. Oxytocin, 10 units IM or IV. Fundal massage, a vigorous 15 seconds minimum. Our labs, type and screen, type and cross. If the patient has a positive antibody screen, we will go ahead and type and cross them for 2 units because it's just harder to match their blood. It takes more time to get blood for them. Stage 1, blood loss more than 500 vaginal, more than 1,000 cesarean. That meets the definition of a hemorrhage. That's the definition of a hemorrhage. So when you hear blood loss, those of you who got a report on a postpartum patient, did you hear them give the QBL? Yep. And so people automatically know, oh, she bled 650, he bled 650, he bled 700, right? You know that's a hemorrhage that's a vaginal delivery, right? All right, vital sign changes, more than 15%, or heart rate greater than 110, blood pressure under 85, over 45, O2 sat drops below 95, right? We're going to activate our hemorrhage protocol. Stage 1 is short. Okay. We need to notify the charge nurse, anesthesia provider. Our vital signs and O2 sats are going to be Q5. We need a team to help us. The patient is actively hemorrhaging. We calculate cumulative blood loss every 5 to 15 and weigh the materials. The provider should do a careful inspection with good exposure of vaginal walls, cervix, uterine cavity, and placenta. The leading cause of hemorrhage is the atony, uterine atony, the inability of the uterus to contract adequately enough to cut off the blood flow to that placental bed. Secondary are coagulopathies and significant lacerations. So lacerations are a possibility as well. Cervixes, especially cervical lacerations, tend to bleed. The cervix is pretty vascular. Okay? So those are on our list. The leading cause is atony, but the other causes are also important, right? And IV access, at least an 18 gauge. Do you think that would be good for planning ahead of time and when the patient's admitted? If they're at risk of hemorrhage, at high or moderate risk of hemorrhage, that IV or saline lock needs to be an 18 gauge? And they need to have one? Yeah. Right? Absolutely. First drug on the list is Methogen. If the patient is not hypertensive, we can repeat it. Otherwise, we need to move on to another drug. It would be either misoprostol or Hemabate. These are prostaglandin medications. This is a PR medication. We are taking an oral tablet and we are inserting it in the rectum. That is correct. This is not a typo. This is correct. It is evidence-based as a protocol. The drug manufacturer does not want to sell it for obstetrics, so they won't sell it with the other labeling. But ACOG recommends this. WHO recommends this. This is from California Maternity Quality Care Collaborative. This is a nation-to-nation status, but the drug manufacturer doesn't want the liability and the cost of liability. So it's not in the book. Yes.
I wonder, how does that affect insurance? Because FDA, I mean, insurance usually won't pay for any medications that aren't FDA, used for an FDA approved reason.
They do for obstetrics.
Of course they do.
Well, and let's put it this way. It's 10 cents. Our other choice is Hemabate, 450 a dose. They're pretty happy when we use meso, actually. Yeah. Yeah. And I'm going to take one more question, and I'm going to ask people to stick to question cards in the interest of time.
I'll write it down.
Okay, cool. Oh, good. Okay. All right. All right. Emptying bladder. Ooh, that's a strategy, right? If a patient has already bled enough to hemorrhage, they need to be type and cross for 2 units. If the patient continues bleeding, if the OB is not already at the bedside, they need to be there. And we need a second OB and a rapid response team. And we need assigned roles, right? If we're going to continue vital signs and weighing materials. They should already have had a complete evaluation. And we may need to send a DIC panel. This is disseminated intravascular coagulopathy. The patient uses up the clotting factors, they may start spontaneously bleeding. You can see bleeding from an IV site, an epidural site. You can see petechiae. And DIC is very serious. If they are in the postpartum unit, move to labor and delivery in the OR. If they're in an LDR room, they need to go to the OR. Because the patient's going to need anesthesia for our next steps. Okay, this is serious, right? We certainly need a second line by now. Bimanual massage means the provider is reaching inside the vagina with their gloved hand and making a, and yes, truly, making a fist and compressing the uterus between their hands. With one hand externally and one hand internally, compressing the uterus to try to make it stop bleeding. That's what bimanual compression is. That sounds kind of rough, isn't it? Right? Absolutely. For vaginal birth, move to OR, recurring tears, a DNC, retained fragments of the placenta can cause someone to bleed, can keep the uterus from contracting. So you can get uterine atony from retained fragments of placenta. You will also see it from membranes. That's a little controversial. You will see textbooks that say that patients can't bleed from membrane. But I will tell you, I had a nice nursing instructor who stood in front of me one day saying, the textbook says that, but believe me, you can have patients bleeding from a piece of membrane. I have lived to see that happen, so I'm going to pass on that wisdom. Is it in your textbook? No, not necessarily. Is it, will I test you on retained membranes? No, I won't, since it's not in the textbook. Does it happen? I promise you it does. Take my word on it. Okay. Place an intrauterine balloon. We'll show you what that is. There's also selective embolization. We can actually block uterine arteries with interventional radiology. Interventional radiology, by the way, is available at Colby, not Pacific. Have we ever needed to put a patient in an ambulance and take them across town? Yeah, every once in a while. By the way, where's that patient go once they've done the embolization? ICU. ICU. This is an ICU patient. Any future ICU nurses, this is good for you to know. Okay, ICU nurses sometimes get postpartum patients. So future ICU nurses, remember your frontal checks too. Gail McLean, you know Gail, right? She's been up on ICU and remember seeing one of our former students and he was telling her he was actually getting 2 postpartum patients into ICU and she says, are they sending you to meters? No. Remember your frontal checks? So yeah. This is why every nurse has this course. All right, cesarean birth, right? We need to inspect everything. Raw ligament, uterus, placental, look for retained placenta. We will do something called a B-lich suture. This is literally, I've got a picture where you tie the uterus into contraction. And we can place an intrauterine balloon. We need to also bring blood by the bedside and start transfusing. Historically, when we were staffed adequately for this, it was a rapid response nurse who would come and give blood. And just transfuse. That was all they did was transfuse. Sign off on the blood with the charge nurse and transfuse. With a pressure bag, literally running blood in. And we are not running it over a half an hour. We might even get a unit in 5 minutes if we have to. So literally running blood. Okay? Blood warmer is good. And 2 fresh pairs of plasma for every 2 units of packed RBCs. Unless we're treating whole blood. We need to look for other coagulation products too. Stage 3 hemorrhage is rare, but it does happen. We need an adult intensivist, a second anesthesia provider, a central line, a social worker, and family support. Okay? We have a massive hemorrhage protocol, also called a massive transfusion protocol, MTP. You hear the term MTP, it's a massive transfusion protocol. And that's when we're like running blood in 5 minutes. And we may need to open up a patient even if they delivered vaginally to do things like a B-lich suture. We can tie off the uterine arteries. We can also do a hysterectomy. Doesn't happen often, but it can happen. And we are transfusing aggressively. 1-to-1 capillary
Mhm.
So do you see that they're going up through an incision and they're going up and tying around and tying nerves into the fascia?
Okay.
So we just
Is that dissolvable?
suture.
Yeah.
We use resorbable suture. Everything but the but the skin suture is actually
It's dissolvable, whatever it is.
dissolvable. Yeah, it's dissolvable. It's gonna get you there. Did I see that
You have this picture on your slideshow.
Did you see it?
Yeah.
Okay. And then did I put battery in there? Let's see. Oh, okay. All right, so common medications. Pitocin, otherwise known as oxytocin, methergin, which causes a sustained contraction, prostaglandins, misoprostol, and hemabate. Also, I want you to circle tranexamic acid. Okay? Tranexamic acid. We can give this quite early to enhance the release of clotting factors. It has been shown to reduce mortality and to significantly cut mortality if we give this early during hemorrhage. So tranexamic acid can be given early, if we need to, if the patient is hemorrhaging. So you'll also see that. There is a hemorrhage cart. It has a scale on it. Anybody ever seen the hemorrhage cart with a, yeah, and you know every delivery cart has a scale on it because we quantify the blood loss by weighing materials, right? So we have a hemorrhage cart. Our nursing interventions are always going to involve continued monitoring, administration of blood products, and assisting. We might be getting people gloves for bimanual compression. We might be scrub nursing, right? The scrub who sets out the instruments and does the instrument count. Even if we have a scrub tech, we might be the circulating nurse doing the count with the scrub tech. If we're in a real hurry, have we ever done things surgically without doing a count? Is that if we have time to count, we do. If we are really, really scared, we might just go and do an x-ray afterwards because our instruments show up on x-ray. That's possible. All right. Intrauterine balloon placement. This is an intrauterine balloon. It looks like a giant Foley. And it kind of is. Can you see that? It's like a giant Foley. Right? It's an intrauterine balloon tamponade. I do have one here. And I just would like you to leave it in its plastic case, but you can take a look at it. It literally looks like a giant Foley. This is the balloon right here. The nurse fills it, by the way. The provider places it while the nurse fills it. And it takes about 200 mils to fill it. I will pass that around for you. So that's a Bacri, it's also called a Bacri balloon, but it's an intrauterine balloon tamponade. So we place it in there, we fill it with water, and then the provider will pull it to provide a tamponade against the placental bed, especially for a low-lying placenta. And remember, those low-lying placentas are more at risk of bleeding. You can imagine this would be a particularly effective strategy for lower-lying placentas. But it can be used for any, if we will try it, right? Laparotomy means we've opened up the patient and we're doing things like a B-Lynch suture. Yes, question?
Yes, the intrauterine, the idea is to provide compression.
Correct. So we're trying to trigger coagulation at that point, yeah. So contraction, but also coagulation, right? We do have both things going on. Contractility is primary, but coagulation still plays a role. So our B-Lynch suture, hysterectomy. All right. I think we kind of have covered this pretty well at this point. All right, here's our B-Lynch suture. All right, so next up, you've got a patient who their bleeding is stable. They've made it past the immediate postpartum, maybe their bleeding is normal or stable. What are our diagnoses? What are our potential problems? Bleeding is one, right? Can people bleed later? Yes. The risk decreases, but it doesn't go away, usually till about 3 weeks. You can have a delayed hemorrhage, and I've seen delayed hemorrhages even up to 3 weeks later. Okay, so bleeding is one concern, right? So what do we do? And what other risks are there? Infection. Infection, and so we're going to monitor these patients, right? Yeah. All right. We've got our focused postpartum assessments. So you know we review histories, vital signs, activity level. We're going to do clean assessments. We're going to closely watch our patients. Remember that initially our vital signs are Q15 times 4, Q30 times 2, then in 1 hour, then in 4 hours, then in every 8 hours. And that represents levels of risk as well, too, right? We're checking preliminary breast exam, diastasis, fundus, bowel sounds, incision, bladder assessments, perineal assessments, lochia. Patients with C-section sometimes still need perineal exams. They still have lochia. And maybe if the patient pushed for 3 hours and had a C-section, maybe they've got perineal edema that needs to be taken care of too, right? Your IV saline water epidural sites, their lower extremities. And we need to talk about lactation, right? Lactation is often our next concern. One of the lovely things about this picture, you see how this baby's body is being held in line and how the baby is facing directly the breast, not outward at all. This is perfect position. This is very nice. And by the way, almost everybody sees a lovely picture like that, and when their hair is sticking up and they're spit up on their shoulder, which is more often the reality of early parenting. Just saying. And we all want to be this small in this person. But you know, we do need to educate our patients that having spit up on your shoulder and your hair sticking up is normal. And feeling tired, right? So why lactation? Why should we recommend lactation? Why is it a nursing intervention to promote lactation? Some real basics here, right? By the way, I can probably give you a 7-page bibliography on the benefits of lactation. Our course doesn't allow me to quite go into that level of detail, but I want to give you some key data, right? If we just took unaltered cow's milk, I want you to realize that cow's milk grows very fine baby cows. I like baby cows, but cows have a lot of muscle and a lot of fat and proportionately not too much between their ears, right? No offense to the cows, they're perfectly lovely, right? All right, and you know, it just so happens that baby humans invest a lot in their brain growth, right? The brain is, what crosses the blood-brain barrier? Glucose. The only thing that readily crosses that blood-brain barrier is glucose. So what do baby humans need? Sweet, sweet, sweet milk. Our milk is, human milk is very sweet. It's very sugary. Healthy sugar, but sweet. It's what they need for rapid brain growth. We don't have quite the same amount, you know, of muscle or fat. So, by the way, do babies have immature kidneys, by the way? Do they need as much protein? No, right? So when we make formulas, by the way, for babies, we water it down and sugar it up. There are old-fashioned formula recipes that involve watering it down and sweetening it up. Things like evaporated milk, actually. When I was in nursing school, I was made to memorize how to hand make formula. We no longer recommend doing that, by the way, so I'm not going to do that for you. Don't worry, don't worry, okay? So not enough sugar. So it is also more allergenic. Cow's milk is more allergenic than human milk. If you gave whole milk to an infant, it also causes micro GI bleeds in the first year of life and can contribute to the development of anemia. This is why cow's milk is not recommended the first year of life. So just regular straight up cow's milk, not recommended, because it actually can lead to anemia because of microgyroids. Okay? So, and again, I like cow's milk. I have it every morning on my cornflakes. But lactation, okay? Advantages, parental antibodies and macrophages. In fact, human milk is hard to spoil. You can sit a bottle of pumped milk and it'll be about 12 hours before you'll get any appreciable bacteria growth, because the macrophages and antibodies are actually also preventing the growth of bacteria that lead to spoilage. Now, I don't recommend doing that as an experiment. Refrigerate it. You'll keep it as safe as possible. The cumulative out of refrigerator time adds up. But it really is very strongly effective. It's been found that even just 3 days of colostrum cuts the risk of diarrheal diseases in half for the next 3 months for a newborn. Even 3 days of colostrum has an appreciable benefit, a remarkable benefit for the baby. There are ideal levels of protein, fat, glucose, also an ideal balance of calcium as well, calcium and phosphorus for tooth development. So there are wonderful things. It promotes brain growth as well as the baby's physical growth. It lowers the risk of many childhood conditions, including insulin-dependent diabetes, asthma, allergies, and obesity. It has been found to have a lasting effect in risk reduction in cardiovascular disease that impacts that child through into adulthood. So there are some tremendous advantages. So there are many, many, many more benefits that are too numerous to count. Okay? Now then, how to prevent problems. Okay? A lot of times people don't realize that lactation is not necessarily easy, right? We look at those beautiful pictures like this one, right? And it looks easy, right? You just hold the baby and they nurse, right? Anybody have an issue with me saying that? Yeah, you should. This person is obviously practiced and posed. It's a perfect position, but and it is absolutely lovely. But it usually takes practice for this to become this easy. This is not easy. Certainly there are reflexes, like the reflex to swallow and root, but it is a combination of learned and practiced behaviors. It is not always easy or simple. Does anybody help somebody get a baby last so far in their rotation? Was it easy or was it something challenging? So she looks to you. Yeah. Anyone else? Please share. Yeah, go ahead.
She was a Q1, and it was learned, learned, but also somewhat known. There's a combination.
Yeah, there's a little bit of a natural instinct.
Yeah, a little bit of
Yeah, it's a combination. Yeah. So the earlier the baby gets to the breast or chest, the better. The earlier, the better. It's been found to double the success rate of lactation if the baby gets to the breast within 30 minutes. Some studies look at within the first hour, or within 30 minutes to an hour after birth. The sooner the better. We want the baby on the nipple, and we want them on the breast or chest. Okay. So the earlier the better. And when we look at the statistics on people who did that, and we look at them 6 weeks later, and we look at how many people are still lactating, it's twice as high for people who got an early start. And we're starting to do this in the OR whenever possible too, by the way, while the patient's being repaired from their cesarean. At least maybe even getting the baby just skin to skin. Even being skin to skin makes a difference. Okay. The more often the baby feeds, the better. Frequency builds supply. All right. How do we know if lactation is successful? we worry about dehydration. So, with a little bit of weight loss, because they came from this warm environment to this cold one, and they had to burn some brown fat. So they got to burn a little weight to maintain their temperature as they're ready to eat. Okay? This is also kind of one of those ideal pictures. Do you see how this baby's mouth is open? I think I showed you this one before, right? We saw that one before, yeah. We want that mouth open. Baby needs to face. There's a C grip, right? And I think we covered latching pretty well before, am I right? Good there, okay. So we do have a latch scoring system. When I give you your family process papers to work on, each of your patients will also have a latch score. You can use a lactation diagnosis once for either the baby or the parent. And this is, but I want you to know what the latch score means, right? L stands for latch. Are they too sleepy? Or do they grasp by tongue down the floor, lips flange, rhythmic sunken? Do they have audible swallowing? The type of nipple, the comfort, the hold, or the help that they need, right? So this is a latch score, and it reviews the characteristics of a successful latch. All right, so our assessment involves the latch. It also involves weight, as we mentioned. It also includes the stooling and voiding patterns. We expect 1 stool for each day of life, up to 4 a day. So on day 3, how many stools should baby have? 3. Yeah, at least 3 as a minimum, right? On day 1, the first day, first 24 hours, we expect 1. Yep, and then up to 4. Voiding, it's 1 per day, up to 6 to 8 a day. So on day 4, we expect how many voids? At least 4. Right? We would expect at least 4 stools and 4 voids on that day. Okay? So we're watching their latch, their stooling, their voiding, their weight. So after that, those first 3 days, right, we're expecting them to have lost less than 10%, and then we expect them to gain. They should be back to their birth weight within 1 to 2 weeks of life. Also, breast and chest changes. We expect the chest tissue to be soft initially, and then it will start to firm. We call that filling. And then it will become super firm and tender, and we call that engorgement. Engorgement usually happens on day 3 to 4. Many of our patients are at home at that point. Usually the breast or chest tissue is soft or filling while we see the patient at the hospital. Milk production increases with demand. So again, the more frequency, the better. Pumps are not as physiologic as a source of demand as the actual baby. Okay. And though they are good when needed, eventually latching is also usually needed. So even though a patient might be pumping because their baby's in NICU and bringing in express breast milk, over weeks and weeks of pumping, sometimes milk supply will tend to drop a little. It's the use of galactagogues, which are medications to help increase milk supply, is a little bit controversial. Probably the best known one is actually Reglan, metoclopramide. It's kind of an off-label use, but it can be problematic. 30% of people who go on Reglan get depression. And imagine your baby's in NICU, you might not be feeling so hot to start with. And then if you take Reglan on top of it, because you're trying to keep up with milk supply for your baby in NICU, that can be a very hard road. So be aware. People do vary, by the way. Is everybody just like this? No. People vary, and if it works, it works. You know, if somebody's making enough milk with their pump and they're happy sticking with the pump, then they're happy sticking with the pump and stick with the pump. Right? But if it's not working, these are the general trends, right? So I want you to know those general trends, right? So usually, eventually, we want to get the baby latched because that will help secure a better supply. If a patient neither intends to pump or to nurse, then the less demand, the better. The fullness and engorgement and compression of the tissue from the fullness reduces the blood flow and will ultimately reduce the flow. Compression is helpful. The less stimulation and expression, the sooner milk production will resolve. Okay. Do be aware that sometimes when patients have late miscarriages, like in second trimester, sometimes, by the way, they will get their milk in too. And they need to know this because it won't hit them till 3 or 4 days later. And they feel betrayed by their nurses in the ER or wherever if they are not told that milk will come in. Some of them might choose to donate their milk, by the way, because sometimes they feel that that's a positive that can come from a difficult experience. Yeah. Second trimester, usually like 15 weeks is, yeah. 15 weeks is usually cited. But, you know, would it surprise me if somebody at 14 weeks, that wouldn't surprise me. And I might tell them this could happen. We're not sure if you're, you know. So, snug sports bras and other forms of compression are helpful, wearing them day and night. Applications of cold, frozen peas, frozen corn, to get all the way around is helpful. Analgesics are appropriate. All right. I want you to keep in mind that infants are born with a stomach as big as an acorn, and it's walnut size at the end of 3 days. Initially, they need to feed every 1.5 to 3 hours, but we feed them on demand. If they are rooting around to things, opening their mouth and sticking out their tongue, they are ready to eat. Crying is a late sign of hunger. So don't wait till they're crying, because then they have to settle down so they can focus to latch. Human milk is more easily digested. Babies will often want to eat more often, and they cluster their feeds. Due to the high metabolic rate of babies, we expect them to double their birth weight at 4 to 6 months and triple their birth weight by 1 year of age. Breast or chest milk is recommended because of its numerous benefits over formula and exclusively for the first 6 months and with supplemental foods from 6 months to a year and beyond. Okay? And we already covered the no cow's milk there and here. Appropriate nursing interventions do include the promotion of lactation and promoting during hospitalization, prevention of cavities. We do recommend that people wipe their babies' mouths when they wash their faces. One corner of the washcloth is for one eye, one corner for the other eye, and then one corner for their mouth. So they learn about, yeah. And cups can begin quite early, 8 to 9 months of age too. These are the WHO standards, by the way, for baby-friendly hospital initiative. These are international standards. And they, at a management standpoint, we should comply fully with the International Code of Marketing for breast milk or chest milk substitutes and relevant WHO assembly guidelines and resolutions, right? So pretty much it recommends that they not be marketed, it recommends that formulas not be marketed directly to parents and that they only be used medicinally when needed or when the parent chooses not to lactate. Okay. No one should ever, by the way, make someone feel guilty. Right? They are loving parents who are caring for their baby however they choose to care for their baby. We want to open the door and respect the answer that we get. So remember Akila? She felt she had endometritis, really struggled with lactation, and then just never wanted to do that again. We need to hear how she felt and respect her answer. She doesn't need education on lactation. She needs to be respected for her decision. Okay. So I think you can be ardently promoting, I think you can promote something ardently, but also ardently respect autonomy at the same time. Okay. Right. There should be written policies that we follow and that are communicated. We should have ongoing monitoring and data management systems to monitor this, and staff need to be trained. Okay, and I'm just giving you an introduction, right? Our clinical management includes discussing the importance and management with pregnant people and their families, facilitating immediate and uninterrupted skin-to-skin contact and supporting patients to initiate lactation as soon as possible after birth. Support parents in initiating and maintaining lactation and managing common difficulties, and not to provide infants that are receiving human milk with any food or fluids other than human milk unless medically needed. If we decrease the baby's appetite, will they nurse as much? No. Will that impact the supply negatively? It could. Yeah. Yep. All right, we want to enable parents and infants to remain together and practice 24-hour rooming in so they can be responsive to the baby's needs. We need to support patients in recognizing and responding to the infant's cues for feeding and counsel people on the use and risks of feeding bottles, artificial nipples, or pacifiers. Pacifiers have positives and negatives. Okay. They do reduce the risk of SIDS. There may be some babies who have nipple confusion though. Human nipples are not usually shaped like pacifiers. The latest evidence seems to be that they are okay in terms of their impact on lactation. But, but there is a possibility too, okay? We need to coordinate discharge so that parents and their infants have timely access to ongoing and supportive care. Generally speaking, Medicaid programs do pay for lactation consulting, including after the patient has gone home. Okay. There are lactation hotlines. There is an organization called La Leche League that have people who are supportive and knowledgeable on lactation as well. Okay. There are such things as tools to facilitate lactation. And so this is referred to as a breast shield or a nipple shield. They come in different sizes. They need to be prescribed. And sometimes the patient has inverted nipples because some nipples are inverted or flat. Sometimes this can help a patient has inverted nipples, help the baby get latched, right? There are also breast shells. When the patient brings up a bra, it pushes against the nipple, and there's a little hole in the center allowing the nipple to protrude. This can also be used for people who have flat or inverted nipples. A breast pump can be used to pull out a nipple also, that can be used. This is a breast pump. Double electric pumps work best, and the best ones are often made by companies that do nothing but make breastfeeding products and lactation products. The companies that make formula and baby foods usually do not make good breast pumps, by the way. If you fail, they make more money.
Breast pumps and the needed supplies are also covered by insurance by law.
Yes.
Recent change, and it's covered 100%. So if you have a patient with insurance who sees the price tag at Target and feels like they can't afford a $300 breast pump, there are breast pumps that are 100%.
Yeah, yeah. And usually they're the really good ones, the rental ones.
They're like Medela and
yeah.
There's another one, but
Yeah.
Medela's one I got.
Yeah. Medela makes a great pump. Honestly, they're one of the companies that make all their money off lactation. If they make all their money off lactation, they're invested in making it work for you. But there used to be one made by one of the baby food companies. It would literally drag your nipple over a rough area, and it would like make you raw. It was not good. It was an awful product. But people would buy it because it was $30 and it was affordable for them. It was one of the cheapest pumps on the market, so people would buy it. And then they would feel bad when it wasn't working. But it was really a poorly designed product. So products do change. And talking with the lactation consultant about the current recommendations is good. The Symphony pumps are the ones we had at the hospital. Those are a $2,000 pump. They're rentable, and the rental fees are paid for. So the Symphony pump is very good. And I owe you a break. So can we do just 5 minutes since we finished another at 2 o'clock? Would that be okay? All right. Let's take 5 minutes break then. Thank you.